Hello, everyone. A very good morning to all of you. Thank you all for joining today, this early morning, for this webinar on rethinking workforce competencies for climate ready health systems. This has been organized by the Asian Collective for Health Systems, whose secretariat is at the Center for Social and Economic Progress here in New Delhi, India. As you know, in most of our region, the South and Southeast Asian region, but really actually across the globe, we're all experiencing the after effects of climate change in ways that actually affect the health of our populations. Heat waves, air pollution, vector-borne diseases are all growing in frequency as well as intensity, which means that we all need to rethink the way our health systems function. And of course, foundational to our health systems are our health workers and health professionals who man our health systems. The training and competencies that current health resources have within the health sectors are largely geared to what we knew of diseases and health conditions of the past. However, we are increasingly seeing that actually human resources, especially those that are at the front line of response, need to rethink and reorient the way they function, keeping in mind the climate sensitivity of existing diseases and also potentially newer health conditions that become much more common or, in fact, are entirely new, as we saw during COVID, for example, that need to be accounted for in healthcare decision making. A big part of that, of course, is ensuring that the training, capacity building of our human resources, particularly those who are already operating within the health systems, who are in service, need to be considered and also rethought by our policy planners. With that background, we have today actually two speakers. We have a presentation of building these competencies from an LMIC point of view from Priyanka Tomar, who will go through a study that we have undertaken here at the Center for Social and Economic Progress and present to you a new framework of competencies. Priyanka, over to you. While you're setting it up, let me introduce Priyanka Tomar. She is a researcher at the Center for Social and Economic Progress. She's also an economist by training and has anchored this particular piece of work that she's going to be presenting today. Over to you, Priyanka.
Thanks a lot, Neethi, and good to be here. Thank you, everyone, for joining in so early. So this is part of our TACS and CSEP research on rethinking workforce competencies, climate-ready health systems. Neethi has sort of already given us a background that climate change is actually, a health crisis. Across the region, we are, experiencing more and more health impacts of climate change in our daily lives. And there are some, slower systems which are also, experiencing the impacts of climate change. So overall, the workforce capacity becomes very, very important when we talk about health system resilience. But if you look at the conversations that happens around health system resilience, usually a lot of emphasis goes on, infrastructural investments, financing. Uh, all of these things are definitely very, very critical, very important. But for real adaptation to happen, you actually need people. Uh, People in terms of, let's say workforce, how workforce are making decisions on a day-to-day basis, how program implementers are implementing these programs on ground, and how basically communities are being engaged uh, in all of these issues. So workforce capacity is something which is very, very important when we talk about climate health resilience. And increasingly we see this in policy discussions at global climate negotiations and things like, nationally determined contributions, which is part of the Paris Agreement. And now countries are increasingly recognizing this need, that they need to develop their workforce capacity, they need to make their workforce ready for climate change, national adaptation plans, and all these things also recognize that, workforce capacity is very, very important if you want to make your health systems more and more resilient. uh, while I say that, we also know that, a lot of countries are reporting that because of insufficient human capacity, they are not able to implement their climate health action plans. So this is definitely a lot of demand coming from the countryside. And even during our research, a lot of policymakers and researchers were constantly saying that we need to keep on investing more and more in, making our workforce ready for climate change. Why are we talking about South Asia and Southeast Asia? We know that uh, climate change is a global problem, and the health impacts are, you know uh, felt all across the world. But we can see that there is some sort of, disproportionate climate exposure in this part of the world. There are frequent heat waves, floods, cyclones, and other things, and that leads to a lot of, service surges. Uh, Also, if you look at disease vulnerability, it's very, very high, especially in South Asia, Southeast Asia. If you look at future projections for malarial disease, diarrheal diseases, it's very, very high as compared to other regions of the world. Also, health workforce capacity in this part of the world is already, we are working at a very thin stretch. There is a lot of shortage, quality issues are already there. uh, there are some numbers here that I've mentioned. There is going to be a shortage of 11 million health workers in low and middle income countries by 2030. And if we talk about, South Asia as a region, then the average workforce density is already, quite low. Apart from this, there are other challenges like data systems in these countries are weak, and there is limited financing. All of these issues, make it difficult, and the need is much more felt in this part of the region. And that's why policymakers and everyone, all other stakeholders need to focus on building workforce capacity in this region. Now, as some of you might know about TACS, TACS is the Asian Collective for Health, the Asian Collective for Health Systems. We actually work across 10 countries in South Asia and Southeast Asia. Our, focus is on building a knowledge hub, a regional learning cooperation. We work on three issues, one of which is climate change and human health. For this particular piece of research, we have done a lot of regional and in-country consultations. We have spoken to policymakers, and policymakers and researchers have, identified that, there is a gap in health workforce readiness. We also did a survey, and the results of the survey also show that most of the health workforce in these countries don't feel that they're ready to deal with climate change. Also, this issue was identified as one of the core priority issue for our regional priority statement that we released before COP30. For this piece of work, we started out by looking at existing training. So we wanted to know, like, what is happening in the what is happening in this part of the world. And then we realized that there are no such competency literature actually, which is only applicable to LMICs or South Asia and Southeast Asia. And then we started to look at the global studies. So there are several global studies which have, these broad competency frameworks. It offers you a broad conceptual uh, understanding of how you can actually design a curriculum or a training, or all of these things. But we realize that on the ground, especially in South Asia, Southeast Asia, these policymakers are looking for actionable guidance, which is quite missing. And that is the thing that we're trying to basically fulfill through this piece of our research. So we are developing, so on the basis of all the global literature that we have seen, we are developing a climate health competency framework. It is called TCP. I'll be explaining what do I mean by this. On the basis of this framework, we realize that not everybody wants to, or not everybody actually needs to undergo the same kind of training. A one size fits all model will not work here. So we have tried to develop something called cadres specific competencies. We already know that in South Asia, Southeast Asia, there is already a deficiency of health workforce. So we have to use them to the optimal capacity, and that's why we have created these different competencies for three broad groups: clinical, community, and public health. We have also briefly reviewed the type of workforce training that is already going in the region. Also looked at some of the project implementations that governments in these regions are doing uh, with development partners and those things. On the basis of our review, consultations across countries, and the survey that I talked about, we are coming up with something called operational strategies, like how can you actually operationalize these competencies. So basically we are suggesting a theoretical framework first, and then we are just developing it into something practical which the policymakers in these countries can make use of. And then we'll also talk about a health systems roadmap that we need for developing climate health capacities, because competencies needs to be embedded in the larger need of health workforce capacity. So this is the framework that I was talking about that we have developed. This is based on a global review of all the competencies frameworks that exist. We have referred to GCCHE, which Dr. Sorensen is going to talk about after me. And we have also referred to a lot of conceptual studies done by researchers. And we've also looked into something called CAP surveys, which basically tells what the workforce feels about the readiness, whether they are ready to deal with climate change or not. So those kind of CAP studies have also been incorporated. So here, basically, there are 5 different domains, and we have classified actually all the competencies that these frameworks have been talking about into these 5 groups. And obviously there is a lot of complementarity here between these domains. So I'll start out with knowledge. Knowledge is you know uh, is a competency which is quite focused in all of these uh, institutional frameworks that we have gone through. Uh, you may talk about any kind of climate health workforce training, and knowledge is the foundation based on which everything else is developed upon. So it basically talks about what the health workforce need to know. So definitely it will have components of climate change, but they also need to know about the policy context in which they are operating. They also need to know about the environmental resources, all of those things. Then comes the systems thinking. Here, because we know that climate change is a very complex problem, and it's a problem which has repercussions across sectors. So as an approach, the workforce needs to have a systems thinking approach, because let's say if there is a flood, it is not just going to create more vector-borne disease. It will have repercussions on nutrition, on mental health, and all those other things. So recognizing these interdependencies and risk are very, very important. And so all these upstream drivers of risks are very, very important to understand. And that's why, as an approach, workforce needs to be adopting a systems thinking approach, which is very, very critical, especially for climate ready health workforce. Then the third is, we need to have the knowledge, but we need to move from the knowledge to from the awareness part to the action part, which is basically captured by the technical skills domain. Here we have things like risk assessment, early warning, research, critical thinking, making decisions, but based on evidence. So basically, health workforce need to invest their time and learn these skills. Then comes communication and leadership, uh, because the workforce does not operate in silos. It has to, collaborate with people from other disciplines, and even if you're working at a community level, community health workforce will have to go and speak to community members and those things. So communication and leadership skills are very, very important here. Then all of these domains that I've talked about so far, knowledge, systems thinking, technical skills, communication, and leadership, all of this will go into practice. So basically, how to act not just in times of extreme weather events, in on a day-to-day basis. A health workforce need to adopt certain practices to be, climate ready. So these are the things which encompasses all these five domains, and we have this is the basic foundation based on which we will be making our recommendations. So on the basis of this KSTP competencies framework, we have gone a step ahead, and we realize that we need to have cadre specific competencies, because this is very generic and general, and we need to pick and choose, like which of these competencies are more relevant for a clinician, which of these competencies are more relevant for a public health professional, and similarly for a community health worker. So what we did was we actually identified uh, what is already there in national adaptation plans, health national adaptation plans, climate health action policies. Like, what are the functions that these programs or are supposed to be playing out? And then on the basis of that, we have, on the left hand side, you will see that these are the functions that we have identified, and then we have classified all the functions that we have identified for three different groups, which is clinicians, public health professionals, and community health workers. And then we have mapped all these programmatic functions to the competency sets that we have developed. Here I am presenting an abridged version of what we have done, but this is quite comprehensive in our paper. So, this is what is needed actually, but there are some observations that we made based on our review, uh, based on the results of the survey. So, for clinicians, we know like a lot of doctors who are operating at the local level said that they are already managing all these climate sensitive diseases, but the kind of training that they receive is very reactive. So sometimes, there will be some ad hoc workshops, or some NGO might start doing some training. So there is no integration of the sort of training in their medical curriculum, and this is something that a lot of countries, high income countries, are also trying to do. They're trying to integrate competencies related to climate change in their pre-service education, and this is what the need is also in South Asia and Southeast Asian countries. uh, for example, Philippines has set up an MOU with one of their colleges for physicians, and they are trying to integrate climate change into their education system. So these are the things that we have identified. Similarly, for public health professionals, their role is very, very important, because they are the ones who are actually implementing all these programs. And so usual suspect is vulnerability mapping, surveillance, and early warning data. So these are the coordination with other sectors. So these are the kind of things which are mentioned in climate health policies, which public health professionals need to address. And they're already doing fairly well, but what is lacking is that there is less attention. There is definitely more attention to how to do a vulnerability mapping or how to make use of surveillance data, and all of that is very very important. But comparatively, there is less attention to operational governance, things like integrating climate indicators into their monitoring frameworks, or aligning with budget risk assessments, or in some countries they are also supposed to be raising funds. So those kind of trainings are not there yet. For community health workers, we know that they are already playing a very very big role as part of other programs also, like for maternal and child health and those things. Community health workers are very very important. So things like household level risk identification, they're anyway doing it, but some of this is not being feeded into the national surveillance system because we don't have mechanisms to do it. And a lot of this is happening on the ground, but is in pilot stage, or so it needs to be institutionalized. And they're already doing few things and which needs to be recognized. And so these are the things for this slide. Then I'm just going to quickly present a country snapshot. So we have talked about that there are a lot of training materials that these countries are trying to develop. For example, Nepal, Bangladesh, India, these are the countries which are taking a lot of initiatives in terms of developing those operational guidelines for community health workers, for clinicians. Uh, there's an example coming out from Nepal that they are very smartly integrating the climate health uh, training components in their other trainings like environmental health and wash workshops. So this is a very smart way of embedding climate health training requirements into basically merging it with other programs. So now I'll come to the recommendations part. So this is what we are trying to suggest. We are not saying that we need to develop a new training systems, because training systems already exist, and a lot of capacity, institutional capacity with respect to training already exist in a lot of these countries. So countries can make use of those existing networks. For example, in India, there is something called IGOT, where civil service bureaucrats are being trained, and all sorts of trainings are provided to them through that platform. So similarly, we see a similar platform in Indonesia, Sri Lanka. So countries should try to make use of their national digital platforms wherever available, especially for foundational training. I would say that uh, this digital model would be very very useful in such a case, because you can achieve a rapid you can do things at a rapid scale with low marginal cost. But there are certain kind of competencies for which you require an in-person presence. There are this is more relevant for community health workers, local administrators, facility supervisors, basically where you have to communicate things in a way where physical presence is very, very important. So these are the things that can be done by role plays, simulations, community, building a community scenario, all those things. Then, as I said, that Nepal is already doing this, that they're trying to uh, integrate their climate health content into existing in-service training. So this is a very smart idea of doing it, and this is something that we also suggest, that the existing climate health content can be part of your disaster preparedness, emergency response trainings, your wash vector control, environmental health programs, NCT programs, and all those things. Then we talk about that a peer-led and supervisory cascade models, uh, especially in countries where there are limited resources. So one of the problem that we frequently uh, hear about from policymakers in this region is that there are very limited trainers also. There are very limited people who have knowledge on environmental health aspects of climate change and those things. So for this, we can develop a master trainer sort of a model where you train certain, people, and then those people will go to their organizations and will train, hundreds of others people. And this is the kind of model which is already followed in a lot of countries here in, for example, in India also, that this training of trainers sort of a model is followed. And uh, it is, you know, it is possible to build uh, a competency check kind of a supervisory checklist kind of a thing within this. And then for the long-term institutionalization and compliance, it is very much important that these competencies are embedded into continuing professional development program, licensing requirements, accreditation requirements, all of those things. Only then, the competencies or the projects that are being developed will move beyond the donor stage. On the basis of what all we have discussed, we thought that it's important to basically give a roadmap, because the kind of training that we are talking about, development of competencies, that can happen only when you have an overall system around it. So this is what we propose, that basically, uh, to begin with, countries need to define the competency indicators, and countries can make use of our TCP domain. uh, and these competencies have to be part of your human resources for health strategy, civil service regulations, and all of those things. And your existing human resource system capacity, the network has to be uh, basically updated so that it can track what all competencies are being acquired by the health workforce. Apart from integrating the competencies into the national network, we also feel that financing is a big thing, and there has to be allocated budget lines for climate health training. There's a lot of global climate finance which is available. Countries can make use of that. And similarly, there are existing data quality issues that exist within each of these countries, and countries need to work on improving that, improving the overall national learning systems. As I said, there are already so many platforms that exist, and we can make use of it. We don't have to create everything from scratch. There has to be investment in long-term research, so that you can actually see the impact of these trainings uh, on on the health outcomes in the long run. And lastly, because there is a lot of opportunity for countries to learn from each other. So there has to be a regional cooperation around this issue, where countries can learn from each other. They can facilitate, joint training and all of those things. So that's it from my side. I'll be happy to take up questions. Over to you, Neethi.
Thank you, Priyanka. We can, before we go on to the Q&A session, I see that we have several practitioners. So we've had a theoretical framework and a presentation of what the literature already says based on the practice experience from a variety of countries. I see there are actually among our attendees some of the people who've been involved in these countries in actually implementing some of those practices, and we'll be keen to hear from each of you. But before we go to that, maybe we can set up the Mentimeter question so that we know who all is in the room. Prakshi, if you can help with the first question, I think you'll soon see a code on the screen in front of you. It would be great if all of you could go to mentimeter.com on your devices, type in that code, and answer the question. So the first question will simply be for everybody, for all of us to know who all are in the room. We'll just ask, which country are you joining us from? Just to get a sense of where all of our participants are from. So type menti.com and use the code 62306415, or use the QR code and you should be able to give us an answer. Maybe another minute. I see a lot of our participants are from India. I think all of the East Asian countries are celebrating the Chinese New Year today. So I see we have participants from Philippines, Malaysia, Sri Lanka, India, and Timor-Leste. Great. Let's maybe go to the next question. So tell us if you have encountered any training or have yourself received trainings related to climate change and health. So we have a very informed audience here. Sounds like most have, in fact. Maybe not. It's about a 50-50. So there are those who are interested in perhaps receiving a training, those who have already undertaken some trainings. So based on your experience then, let's go to the third question. Can you reflect on your particular context and tell us what was an enabling factor that helped you get this training, or you think that would enable this kind of capacity building on climate and health within your respective contexts? If you can identify one word. Scale. Alerts, okay. Grassroots level health workforce. Hopefully soon we will be able to ask you to unmute and share a little bit more about each of these words. Expediency, yes, I think that's likely true for most parts of the globe, really, but particularly this region. Community, collective, grassroots, these are all words that are coming up quite strongly, and ownership for sure. let's maybe go to the next question where we talk about the downside then. What are then the barriers? And again, if you can just identify one. Resources, yes. Awareness. Enforcement, political will. So both concrete inputs, but equally awareness and appreciation that needs to actually be, that's needed for implementation. Technical capacity. Hopefully, the kinds of framework that Priyanka just presented will help with that. Fragmentation of the actors. Great. So clearly, there are still quite a few challenges, but there are also several enablers. And I think I'm going to open it up to the audience and listen to some of the practitioners. Our keynote speaker, Dr. Cecilia Sorensen, unfortunately has had a last minute unanticipated emergency, is unable to join. But hopefully, we can reschedule with her and ask her again to share her experience and her team's experience of running the climate and health responders course. But before we do that, at another date, hopefully, and I'm hopeful that all of you can join again uh, to listen to that conversation and that experience. But we do have uh, several others in the audience, and I'm curious to hear. Let me first go to Tandi, one of our collaborators. Tandizile Sibindi, if you could unmute yourself, Tandi, and share a little bit about the work that you have done, particularly among building eco health capacities among the nursing staff. Tandi, over to you.
Thank you. Good morning, Neethi. Good morning, all the participants. I'm Tandazile Sibindi. I'm currently a policy research associate here at the United Nations University Global Health think tank. But I did my PhD in South Africa, which was in response to the clarion call by the WHO to all universities to ensure that the health workforce is knowledgeable and has the capacity to address the contemporary health issues brought about by the climate, the changing climate. So my study then developed a set of what we called the eco-nursing competencies for nurses working in primary healthcare. Our focus was in primary healthcare because we believe that this is where all the climate impacts first show up: the heat-related illnesses, air quality exacerbation, you name it. And then the focus was specifically on primary healthcare. The focus was specifically on the nurses because they are the backbone of primary health care, especially in developing countries where you at times may not find even a doctor at this primary health care facility. So we believed that equipping this nurse would ensure that the people that they are going to be in contact with will also be protected. So this framework was developed using a multi-phase convergent mixed method design, which was anchored by the iChange model to structure how the awareness, the motivation, and the behavior could shape the competencies and behavior change, which is needed in ensuring these climate smart competencies. And then we also used the South African Nursing Council competency framework domains and the subdomains to ensure the alignment with professional roles and regulation. Like the previous speaker has said, these competencies, they do not have to be parallel with what the health workers are already doing, but they have to be embedded into what they are already doing. So this study has developed several papers. There is the economics and competencies, which was a scoping review that was done, and the paper was published in 2024 that did some global search on what's the trend globally. And from this scoping review, we identified that the nurses can be involved in research, in education, in advocacy, leadership, as well as the clinical practice in trying to ensure a climate resilient healthcare sector. And then the second study was on trying to find out from the nurses themselves how much they know about climate change. And that's where the iChange model was used. And we adopted the international tool known as the Climate Health and Nurses Tool, which was adapted from Schenck, which they developed in 2021. And the paper is currently in its final stage of peer review. And then we also had to do another study to find out from the experts to see what they think could be the barriers to implementing these competencies among the health workforce. And then the article is under review, but the preprint is already out. I would pop in the DOI in the chat. And then from these findings, we then went on to look at, to do the evidence synthesis using the critical interpretive synthesis to come up with a preliminary economics and competency framework, which was then validated via a modified Delphi to come up with a framework that consists with 62 competency statements organized into 14 subdomains and five domains. So just a brief look at what these domains look at. The first one is the need for climate and planetary health literacy, which has already been identified by the previous speaker. So there is a need for the health workforce to recognize the local hazards, the exposure pathways, and the vulnerable groups. And then the second domain being the clinical practice and resource stewardship, where eco-informed clinical decision-making is needed to improve the people's health outcomes. And then the third domain being the risk assessment, preparedness, and continuity, where there is need to integrate heat, air, or water risk checks, contributing to facility emergency and continuity plans. And then the fourth was the health promotion and the community engagement, which nurses have to be leading in to make sure that there's climate readiness among the communities. And then lastly was the leadership quality improvement and the advocacy competency that is needed among the health workforce. So maybe just a few takeaway from this competency framework that is still going through the peer review for it to be published. The takeaways could be, we feel that it is not an add-on, like I've already said, because it is already aligned to the nurse specialists that are closely working with the communities in South Africa. That is the primary healthcare and the community health nurses, and it's ready for adoption and evaluation. Looking at it being detailed enough to influence the curriculum, clinical mentoring, and research practices. So in a nutshell, I think that's what I can say about my study and the economics and competencies that have been developed. Thank you.
Thank you, Dr. Sibindi. From your experience in South Africa, and now I know that you're practicing in Malaysia, could I quickly ask you what you think of why is it needed to develop a framework? How applicable are the findings from South Africa potentially to maybe other countries? To what extent would you say, for example, the eco-nursing framework and maybe the KSCTP framework that Dr. Priyanka presented are actually applicable more broadly?
All right. I believe that these economics and competencies, they are not a standalone. when it comes to what the nurses already know or the health workforce already know. So their applicability to the current place where I'm practicing it, I feel they are applicable because having developed a framework, you can readily create curriculum from that framework. You can readily implement it in practice using that set of competencies, because you can simply pluck out maybe one or two domains which you can then use in continuous professional development of this health workforce. And then you can also incorporate maybe in clinical supervision or in up-notching of the nurses in their day-to-day nursing activities. Thank you.
Thank you. And I think it's important to note that while your framework looks at nursing, really in practice, health workers work as a team. So there is a combination of different kinds of cadres who work together.
Yes.
And in this webinar, we're largely talking about within the health sector, but I see there are questions from the audience that are already pointing to more intersectoral and actually people from other sectors and how their capacities need to be built. Maybe I'll go over to Dr. Ronald Law from the Philippines. I see there is also a question here, but if I could request you to unmute and share a little bit about what Philippines is doing. And we saw from the previous presentation that Philippines is one of the countries that is actually moving forward quite rapidly in this area. And if I could ask you to unmute yourself and share a little bit about your practical experience, and then maybe also the question, and we'll go over to Priyanka to try to answer that. Over to you, Dr. Law.
Hi, Neethi, Priyanka, and everyone in the call. Glad to be part of this important conversation on health human resources. Yeah, in the Philippines, we are implementing our climate and health roadmap, and in the Ministry of Health, we set up an office. So it's new, therefore, that's why this is related to my question. That yeah, because we have to be scaling up our initiatives at the health system level. That of course will encompass clinical, public health, and community. But for us who are doing the actual work that goes to this specific competencies, so we ourselves would need to be targeted for this. And I think developing this framework is very important, so much of which are relevant and applicable to our setting. But because I've been involved also in this climate and health responder courses that are really looking at the different contexts of the regions, but it might be best if we can contextualize better, so we can work with this framework, but I believe there has to be contextualization. And like much of the people delivering this teaching in this courses should be coming from where this uh, climate issues are happening. So I think that's very important, because even in the Southeast Asian region, the Asia as a whole, I think there's a lot of granularity in terms of our experiences. And I think we need to really capacitate people to to be part of that training cadre as well, and making sure that they really relate to actual things that people experience in these places. So I think that can help a lot in terms of being able to apply it to this context. But I don't like to believe we're starting from scratch. We have had a lot of experiences already. And yeah, that's I have three important points. So first, I think we need to capacitate the actual teams, people working on climate and health, because there's not much of these teams doing its thing. But I think that is kind of immediate, because the framework development finalization will take some time. But I think we have to focus on what's more important. And then secondly, the added context is very important, and the the people teaching them should be from this, the makeup, the composition of the training team, I guess. So locally developed, as we know, it's not only better, but it's more uh, effective. And the thirdly, maybe the way to do this, maybe a regional platform of sorts. So I believe really the current direction of building climate and health hubs is very important to 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 see this through. So thank you, but yeah, we are, and then maybe we have to be deliberate in terms of targeting. Yeah, because like nurses have always been very helpful. Like within medical communities, that can always be a challenge. So in the Philippines, our primary care doctors, our family medicine specialists are leading the charge. So much of our initiatives now are working with them. So I think it's very important per country if we can identify who these important groups of medical professionals are. So I think clinically this has to be settled. So I think the approach has to consider this as well. So at the end of the day, each country will know best how to implement this. But I guess the framework is very, at this stage, very helpful. But much contextualization may need to be done, and then the way they will have to be delivered may be coming from the people in this places, are because we have to grow them to be experts as well. Thank you.
Thank you for that. I think actually two very important points that I would like to underline. One is the fact that we need to think about the teams and the teams that are actually operational on the ground. So while these frameworks and this framework building are useful, we do need to identify those health workers, and really that includes a mix of, frontline, for example, community health workers, as well as health professionals who are working in clinical settings, potentially nurses, doctors, and also likely public health managers who are involved in doing surveillance and perhaps also other higher order things like climate modeling and so on. And for all of these people who are familiar with the context, who are already working on the ground, and for their capacities to then build up. And as you say, Dr. Law, I think in all countries, we do have all of these three cadres, and they do have some existing capacities, even if they are much more, inclined towards the diseases of that we already are familiar with in our respective contexts. And partly that was our approach, for example, for the KSTCP framework, and actually disaggregating it based on these three types of cadres and the practice requirements that their climate and health action plans actually ask them to do. And what are the skills, what are the specific skills that each of these different types of functions actually require, and how can they work together? So that's one very important point. The second, I want to pick up actually from what Tandi had also brought up in terms of regulation and the training capacity. So the trainers themselves in each of these countries, and there, as you suggested, Dr. Law, perhaps there is much more room for a regional cooperation to actually build our capacities on the initial group of trainers. And once again, we did see from Priyanka's presentation particular examples where there were the training of the trainers kind of approach, and then the cascading of those subsequently. So, and I'd like to open it up for everybody in the audience to please share more of your experiences. I'll and any other thoughts and comments that you would like to have about what might work well or not. You'll see that we're also trying to identify the strategies for how these trainings can be given. As you mentioned, of course, we have the model of the climate health responders course, which is largely online, even if there has been some degree of tailoring for different regions and some examples, practice examples, but it's largely online, and it's a mixed group of participants. Maybe the targeting that Dr. Ronald Law just mentioned about different kinds of health workers is something that can only really be done in country. So I'd like to hear more. If there are other examples from others in the audience, then please, raise your hand or type in your comment or question in either the Q&A box, and we'll allow you to unmute yourself. I see there is one hand up already. Arman Chaudhary, please feel free to unmute yourself. I see that you also have a question. Over to you. If you can unmute yourself and share your thoughts.
Yeah, thank you, Neethi. Hi everyone. My name is Arman, and I'm working currently as a JPAL South Asia Climate Health Fellow at Collect a Good Foundation. So while I'm working on data systems and integration of climate and health data, we are working with very small cities in Uttar Pradesh called aspirational cities, and we are working with the urban development department there to strengthen urban health systems and help them become climate resilient. A key component of this was to train the ASHA workers, ANM, and CHOs on ground for the upcoming heat season. Because from the data we were able to collect for the last few years, including health news articles and administrative data, we realized that a lot of cases were being reported in East Uttar Pradesh. So one of our cities is there in Bahraich district. So when we were training the health workers of different cadres, as we were talking about, right, we realized that there is a need of different approach on how do we take upon each of them. Because when we were talking about ashas, right, they said that they know a few things about them, because as we said, there are sometimes trainings, or especially when heat waves are about to happen in states like Uttar Pradesh, there is IEC material rolled out, right? So they know some bits and pieces, but the main issue is to close the loop and help them understand the broader aspects, right? But we also found that many times, even if you prepare very complex modules, covering all the aspects, thematic areas, but sometimes it doesn't reach to them. It is not very helpful, right? They will come and sit and like you are doing this conversation with them, but it doesn't really help until and unless we talk about their local pollution conditions, right? Or their local climate health disease risks. For example, this particular area, the main issue is that when heat is combined with humidity, it becomes very difficult for them to do their day-to-day lives, right? And let's say heat waves. So we also found that when we were giving them examples from their own areas, on their own state or their own district, that helped them relate more and also share experiences. Because I think these frontline health workers have also a lot of information that can help us as also as trainers to realize something more about the climate health situation in that space, right? So I realized that when we talk about customization, when we talk about one size doesn't fit all, I think as much as possible, when this is institutionalized in future, maybe focusing on climate health regions and maybe going by IMD climate subdivisions, right? If we can have a small module where we talk about that particular subdivision where these climate health workers are working, I think that would be a great step to make these actually actionable and useful for those health workers. Yeah.
Thank you, Arman. I think once again reiterating the points that both Tandy as well as Ronald had raised about the contextual realities and using that to connect with the people on the ground. So, and your suggestion of actually including maybe a small section of the training on just acknowledging what those particular climate related aspects in those areas might be is useful. And I also want to highlight some of the things that Priyanka mentioned in terms of the operational strategies. So of course there are these formal trainings such as the climate and health responder trainings, but potentially other trainings that governments and departments can run for their health workers, including in-person workshops and so on. But there are also peer-to-peer kind of learning mechanisms, including the use of, for example, cell phones or local news media to highlight some of the issues that you mentioned, Arman. I think there is room for, we see that, different cadres actually learn differently. And as you point out, for the frontline cadres, the community health workers, the likes of ASHA workers and ANMs potentially, there's a lot of scope for locally contextualized learning that they actually get from each other. And having a program or having a structured approach is very important, but equally I think departments and governments and the formal training processes need to also use these sorts of informal training and capacity building mechanisms. And we do find some examples of that already reflected in Priyanka's presentation. I should say that so you had also asked in the Q&A about how this research can be accessed. So we do have a paper forthcoming that we would, of course, share with all of you. There will also be some kind of a brief, and maybe this presentation as well can be disseminated more widely if that's helpful. But some of the more detailed examples will be in the paper that we will be circulating as soon as it becomes available in the public domain. And you'll see that there are these details about locally led training or locally led capacity building that uses a combination of formal and informal training mechanisms. But thank you for that. I'm going to now go to Kranti Vyasaraju, who's raised several questions. Kranti, if you could unmute yourself and share what you've typed in the box about the ward level climate action plan.
Hi, Neethi. Hi, Priyanka. Thank you so much for this. The framework is super useful. Things that we know, but then to see them all put together is a really useful tool. I think a lot of the question that I have asked has sort of been addressed as you answered other questions. But I was just looking at how urbanization is really, again, a huge stress factor for climate change, and how urban planning needs to be also incorporated into how we address climate and health, especially in terms of dashboards, in terms of responsiveness, in terms of alert systems, etc. So I was just thinking whether there has already been thought put into how we can have certain trainings that are for across different sectors. And like one of you mentioned also, right now, I think the number of trainers is also limited. So a plan in terms of how you will sort of propose that this sort of capacity is also built in the first place. Thank you.
Thank you so much. And could you also share about the Greater Bangalore Authority's working group that you just mentioned in your comment, and the different kinds of sectors who got involved, and what that, and I think it would make for a good good count, another example, let's say, similar to what Arman had just shared.
Yeah, thanks a lot. This was recently done where I think even the BBMP for Bangalore has now moved into something called the Greater Bangalore Authority, and they have something called the Climate Action Cell, and they brought together fellows. They put together a fellowship under that Climate Action Cell, and they brought together a working group of experts across different sectors, like I mentioned. So they are looking at waste management in the city, water and waste, water treatment, etc., disaster management. So they've brought together experts across different sectors and taken them to different pilot pods in Bangalore. And where the working group has identified climate related issues that might be there in the ward, but then they also went and took these findings to the public and did a consultation where the public was also able to, say, okay, you have identified such and such as an issue, but then, the footpaths are really an issue for us. And that is also sort of comes back to health, right? Road safety. So if there are so many connections like this just from urban planning that sort of come into the health sector, that it sometimes just, I think we're still stuck to infectious disease because it's the most stark one for us to see. But then there's a lot of road safety and well-being, like having a lot of parks. So we need to have people from the health sector also participate in urban planning. So that also requires some sort of training and some sort of perspective building. So I just wanted to raise that also as an important observation.
Thank you. And actually, that is a useful example potentially to what Dr. Law was asking about. How do you build the capacity of the planners themselves? And what you said, so this municipal body in a provincial capital is actually building a team with sector experts, a multi-sectoral expert committee, if you will, who are then offering training through fellowships, if I understand that correctly, uh, to
There is
the.
one, yeah, sorry, just a little bit. I don't know too much about the fellowship, but then those are the sort of anchors within the government that then sort of, talk to the rest of the sectors and put together this whole report and everything. So they've also built a capacity within the government that sort of anchors this whole process, which I thought was also a very interesting model.
So the use of things like consultations in itself potentially builds the capacity of the planners. Is that right? Do I understand that correctly?
Correct, correct.
Very interesting. Thank you for sharing. Sanjeev Kumar, if you'd like to unmute yourself and ask your question.
Hello, I'm Sanjeev
Yes.
Kumar. I'm from Mamta Health Institute for Mother and Child. My question is because health workers, comes from a very different background, like clinician coming with a very robust set of trainings, 3-4 years trainings. MLTs are coming with like just a 1 year diploma training. Pharmacists are again coming from mostly diploma background. So how will the defined competencies could be delivered so that their, knowledge, attitude and skills could be built? Have you gone through any such type of, mechanisms through your, work? That would be really helpful for us.
Priyanka, would you like to answer that?
Thank you, Dr. Sanjeev, for your question. And even when we started to do, when we started out with this research, this was the question that I was discussing with Neethi, that there are so many different cadres, and the needs are so different. So how are we going to build a framework which is going to capture everyone? So we started to look out for like what already exists. And if you look across global frameworks, so those global frameworks are meant for an interprofessional audience. They are not making any distinction there between different kinds of cadres. And I agree with you that the needs are very, very different for the kind of cadres you're talking about, which are pharmacists, lab technician, but there is no customized framework yet. Maybe we can also extend our work, and this is a research gap that we also identified, that there are certain cadres which are not identified as such differently. For example, Thandi also talked about eco-nursing competencies. So nursing is one area where they are very clear, and there are a lot of nursing associations that are talking about having a different competency framework altogether. For clinicians, you will be able to find that out, but for lab technicians and others, there is no framework as such. But yes, based on the framework that we have developed, these things can be customized. Thank you. I hope I answered your question.
And if I may add to uh, add to this process. So some of these, the kind of capacity building, as was just mentioned, the process of building capacities and potentially having a program and and gradually implementing that in itself can help the allied professionals, including, for example, the lab technicians and the pharmacists that you mentioned, to become much more aware. And there are studies that have found that just the fact that there is a program that is being implemented on health and climate change, and the programmatic aspects of the implementation itself can support some degree of capacity building. I think the distinction is also, and I think your question about all of these allied professionals, including pharmacists and lab technicians, is very important, because we are currently at a stage where we're very nascent and really very early, the beginning stage of building capacities. And there's a difference between having some awareness and some capacity to to be able to do the work that's strictly required, the basic minimum, to be able to do it really well. And resilience, especially in given the uncertainty that climate change brings, means being able to do these skills really well at times when it is required. So in a way, these are skills that potentially, especially among these allied professionals, may not get to routinely use, but we need to have enough of this knowledge and skills percolate down to the entire system, so that as and when the need arises during, for example, a heat wave or a flood or an outbreak of some infectious disease, whatever they might be, that they will actually be mobilized. We can mobilize all of these professionals, and I think that's potentially the hard part. And again, things like simulations that have been suggested from the literature and was presented by Priyanka offer some ways of doing it, but it's a very important question, and hopefully we'll get there eventually. Thank you for that. Would anybody else like to? Manjunath Shankar, please go ahead. I see your hand is up. By the way, please feel free to turn your videos on. And if you'd like to not speak and just type your comments or questions, I'm happy to read them out on your behalf as well. But over to you, Dr. Manjunath Shankar.
Hello, can you hear me?
Please go ahead.
Yeah, actually, my wife was also on the webinar. She will like to give a talk. She will like to.
Hi. Hi, I'm Purvi Patel. I used to work with NPCCH before. So because the discussion is going towards, different aspects of climate change and health, what challenges we found is that, like, you need to think about how these trainings are being conducted for different cadre. So, like, nursing will be done by the professional bodies, and the ASHAs and ANM will be trained by NHSRC and NIHFW, and the health professionals, medical officers are trained through government's own a framework of training, which is already there. And so the thinking should be like, who is training who, and that will be very helpful for you to identify like who are the bodies you should approach, where your trainers may be placed. That kind of thinking should be there. And also one observation that I had is sometimes what happens is the trainers are invited to train the people, but they usually end up talking about their own research. And so what happens is a consolidation of knowledge and synthesis of knowledge, which is very relevant for practical aspect of some, the people who are there is somebody has to do that. So I realized that it's not just the expert, but somebody has to sit and synthesize all the knowledge, fit into existing system, and then make it relevant for the people who are in the audience. So those are the different aspects that I experienced from when I was training in NPCC, and I just wanted to share with you. Thank you.
Thank you very much. And a reiteration of what Ronald Law was saying about the context. But can you tell us a little bit more about your role at the NPCC?
So in NPCC, I was in charge of a heat and extreme weather event, and lately on climate resilient health facilities, and some of the things that was like the main part was technical development of the program. So I was looking after development of training modules, which are also developed by some of the COEs, and translating them to the actions, helping in the policy change and also implementation of action plan. So I was in the midst of it, and also trained people on heat and health. So that was one of the core area that I helped develop in the program, training of heat and health. So that was my work with them. Yeah.
Thank you. And can I also ask you, how did you build capacities of the planners and the policymakers themselves?
So as you know that the program has their own nodal officer on state and district level, right? So whenever the training happens, the national level training involves the state nodal officers, and then they are they have to impart that to district nodal officers and then district nodal officer medical officers. That is like in-person training cascading follow-up. But in the national level also we did webinars and like nationwide trainings where all the medical officers and residents and pediatricians and physicians get trained. So that was this is the way that all the health trainings have happened in other programs, and that we follow the same things. And the nodal officers were the health administrators. So that's how it was followed.
Thank you.
Yeah, thanks.
Would anybody else like to speak? Unfortunately, we were supposed to have a keynote presentation by Dr. Cecilia Sorensen, but due to an emergency situation, she's unanticipated last-minute situation. She's been unable to join, but hopefully we can reschedule with her. But I'm going to now hand over the mic to Pallavi Kumar, who has her hand up. Pallavi, please go ahead, unmute yourself and share your thoughts.
Hi, Neethi. I hope I'm audible. Yeah. So, hi everyone. I'm Pallavi. I'm representing Japaigo, and we work closely on the National Program for Climate Change and Human Health, and closely associated with the NPCCH program in India. I think what you're talking is quite relevant in terms of building the competency of the frontline workers and also the service provider who are involved at the various level. But the biggest challenge, what we see, is the intersection when we talk about the intersection of health, climate with other programs. For example, just now you talked about the intersection of climate with the nutrition or intersection of the climate with the mental health or other thing. I think there is also need to develop that competency between the program managers to bring the intersectoral learning and also interdepartmental convergence, because that is a area where I think we do not have much of the evidence, neither we do have a clarity in that what exactly needs to be done at the intersection. So we are quite clear on the extreme weather conditions, the climate resilient health facility, but as we are evolving into the climate space, these are the areas where we need to have more of a brainstorming in terms of how we want to build the competency. So based on my learning, I just wanted to bring up front here because you are working a lot on the research component and also interacting with a lot of the thought leadership. Yeah, Neethi, thank you.
Thank you so much for sharing that from the practice. So we absolutely want to bring in all of these. One of the reasons for having this webinar is also to get your thoughts from your respective context. So all of this practice related aspects are super important, and that will be translated into the research that we're doing, and actually also the work that we're doing with the different climate and health focal points across 10 different countries actually in the region. So thank you for that. And I also see that there is another comment from Kranti about the fact that there are often tools, including policies and dashboards, but there's often poor enforcement and accountability. For example, dengue surveillance depends on tests that are not always easily accessible. Plus, we know that dengue is known to be affected by heat and floods. However, the policy still insists on tests which are not always available or accessible, which can beat the purpose of surveillance. The accountability of the leadership level is super important, and potentially training and capacity building therefore may not be the only solution that can help with all of these aspects. So we also need to build accountability among the leadership, and that so the framework needs to capture the operational aspects, but also the learning health system, which includes things like political will that some of you already brought up, accountability, and potentially bringing in all of the layers of the health system, which was again mentioned both by participants as well as in the presentation. Thank you. May I also, please feel free we'll be sharing a recording of this presentation. We'll also have all of you and your email IDs, especially if you're able to put those up on the chat box. We'll add you to our mailing list so that we can circulate all of the materials as and when this becomes available, the final version of it. We'll also hopefully be rescheduling with Dr. Cecilia Sorensen and have her speak to all of you and others as well at a later time when she's able to join us. And this is a piece of ongoing work. And feel free to share all of your thoughts with us. If I can request my Prakshi and my colleagues to just share our email ID for the Asian Collective in the chat box. I'd welcome all of your thoughts and comments. And feel free to write in with any resources. I know some of you already mentioned, Tandy, you had also mentioned some of those papers. If you'd like to share those in the chat box for everybody. And in any case, you can write to us at contact@asianhealthcollective.org. That's also now in the chat box. So you can feel free to write to us. With that, I'm going to hand over for last minute thoughts to Priyanka. And if anybody else would like to have any last words, please put your hand up and I'll unmute you as well. Yes, Sanjeev Kumar, please go ahead.
Yeah, just want to emphasize that, there are lots of health outcomes are being, labeled as climate sensitive diseases or conditions. But when you see lots of associations are coming up, but causality is yet to achieve, right? Yet to establish, right? So I think rather than going to the health outcomes, which has been labeled as a climate related health conditions, we should more prioritize on the hazard based set of context. Like heat is one of them, air pollution or is another one, right? So that we can actually come up with the competencies list that could be easily adaptable to the different cadres. Otherwise, the moment we will jump into the climate related health conditions or the diseases, I think most of the health conditions are being labeled as a climate related health conditions. So that would be, I think it will be difficult for defining competencies. So I think we should more focus on the hazard rather than going to the health outcomes, which has been labeled as a climate related health conditions. That's all. Thank you.
Thank you for this. But could I press you a little bit and ask you that regardless of the hazard, and maybe to share also a little bit of our approach, regardless of the hazard, the people who are responding on the ground typically tend to be the same health workforce.
Yeah.
And in a way, we cannot have, separate trainings, let's say for heat and for each of the different types of hazards. And what we really need potentially is a building of the overall system capacity to be able to learn regardless of the hazard. So that's sort of the way we approach this problem. But if I can press you to share a little bit more about why you think a hazard specific approach is actually more suitable.
Because hazard is something like where most of the climate related intervention has been designed, right? When you see the NPCCHH or even WHO framework, where even when you see like WHO facilities, assessment tool, where I think it has been more designed on the hazard based, right? So just for example, like think about like heat related illnesses, right? You have a very different drives to actually manage those conditions, right? So if like in another scenario where we prioritize, like malaria is one of very a very well established climate related health illness, right? But again, the intervention which we will make, right, it will be the totally same, right? Even like when you might be, you can change like when the shifts happens during the seasons, right? That time you can activate your community health workers to respond, right, to create awareness, even at the facility level. Most of the even lab centers are available, right? Everything is available. So that's why I'm saying, right, if you will take the disease by approach, might be you will not ended up with good set of competency. But if you will try to do so, almost the same, right? If you want to build competencies of malaria related conditions for MLTs, what the additional thing we can add on? Nothing. Because when, like, previously I worked on developing competencies for MLTs, all are same one. You will not find even additional anything, right? So that's why I'm saying, right, if you want to come up with the specific set of competencies framework, we should more focus on hazard. That's all.
Right, I understand. You're saying rather than looking at diseases, it's better to look at the hazards. Thank you. Dr. Ronald Law, I see you have a suggestion for some resources as well. So if I could ask you to unmute yourself and share with the larger group, and then I'll hand over the last words for Priyanka to close today's session since we're nearly out of time. Dr. Law, and then over to you, Priyanka.
Thanks, Neethi. Yeah, I've shared that in my previous role, we've done a lot in building the core competency. This is led by the WHO on health, emergency, and disaster risk management. So we look at the different domains and different competencies, and I think this can be a great resource too. But just to share my thoughts on the approach, I think like for countries like the Philippines, we have to have some orientation on climate and health just to give that extra focus. But we believe it should be part of our module on multi-hazard approaches, because we have a strong foundation on emergency management, right? More on the hydromet stuff, but we have to bring in the newer ones. For example, heat is something that we have to address. So for now, we've been doing webinars. We're thinking of developing courses or topics, but mainly in line with existing training courses. So we believe this should be in line with our emerging infectious diseases, and all the other environmental health issues. Yeah, so I think it should be a mix of different things. There will be trainings, modules, orientation. So I guess countries will have to best decide which would suit them best. And of course, in the context of low middle income countries, yeah, it's always best, and that's what we teach, that this have to be built around systems, and we cannot just be adding too many courses, too many topics for very busy implementers on the ground. And this is very important in the Philippines, and I guess this really drives home the importance of embedding it in our curriculum pre-service, before they are trained professionally, before they are deployed. So we also are putting a lot of efforts in terms of that. So like we've started doing we've been doing a lot of disaster management integration in the curriculum, but we are making sure that climate and health competencies are part of that. Yeah. But of course, climate and health is a topic that is gaining a lot of traction now. So this is one of the asks coming from our implementers. But of course, at the system level, the way we have to plan it, approach it, it has to be built in. So I guess that requires a lot of thinking. So for us now, informal is through attending climate and health responder courses. But we'd like it to be more formal in the way that, yeah, we are thinking of developing this course. Of course, developed by us, catering to our people. So I guess that's something we can share in the Philippines. But of course, we also want to learn from how other countries are doing it. So at the end of the day, I believe it's not merely technical competencies that we're trying to add, but more on, strengthening really our health system, our health workers, to make them, suited to this new requirements. Because at the end of the day, I think we are also, shall I say, incomplete or insufficient in terms of what we got. So I think that also should really prepare us to work well with other people. Because, yeah, I think that has to be the approach. So this is going to be team-based, and this is going to be, whether we like it or not, interdisciplinary. So there are just things that we can do for our people, but I think there's the other aspect of really being able to relate well with people who's got other competencies. Maybe they are in the different sectors. So I think the coordination, collaboration work that has to be done should be addressed in our framework. So I'll stop here, Neethi, and it's been I've learned a lot, and yeah, I am inspired more, and I know that we have to do more to make these things happen. Thank you.
Thank you so much. So intersectoral, integrated, and iterative. I think those are the three things I pick up from you. And I just want to, to the point about different countries and the local realities, I just want to highlight the comment from UNU IIGH, who would like to collaborate with different countries to provide trainings to incorporate some of these competencies. So just like UNU IIGH, who are a partner of ours, I should say that we're also trying to work with partners, technical partners in different countries who can help translate the competency framework that Priyanka Tomar presented into a locally contextualized capacity building program in the different countries that we work in. So with that, Priyanka, over to you for last thoughts and to close the seminar. Thank you very much to all of our attendees, our participants, and we look forward to keep the conversation going with all of you on this and other topics. Over to you, Priyanka. Bye-bye.
Thank you, Neethi. Thank you, everyone, for joining us. And I think we got really useful insights for our research, uh, especially the comments by everyone. Dr. Ronald Law, talked about that all of this is okay, but climate change is happening right now, and you need to capacitate your climate and health focal group to be able to do more. So I agree with him. Simultaneously, this work of developing competency frameworks, basically institutionalizing, having clearer pathways. So I agree that South Asia, Southeast Asian countries are already doing a lot in terms of, building up the workforce capacity. And we are not, as everybody said, that we are not starting from scratch. There is already a lot of knowledge, but now maybe it needs to we need to look at these things from a climate health specific lens. So this is very important, and we need to have clearer pathways. And I hope that the research that we have done would be useful for policymakers to contextualize, customize it according to their context. And we look forward to engaging with you all in our future seminars. We have shared our email IDs here. Neethi's email address and my email address is there if you want to, speak to us more about this part of the research or have more feedback and suggestions. We are very much, eager to hear from you. Thanks a lot. Thanks a lot, everyone.
Thank you. Bye-bye.